Let's talk now about the definition of autism. And as you know, as of May of this year, DSM-5 came out. So I will do a little introduction of DSM-4 criteria and then focus on what the DSM-5 criteria are, which are fairly similar, just a different conceptualization of the problem. First of all, we're referring to autism now as a spectrum disorder. And a spectrum means that we can have any combination of symptoms with any degree of severity, which leaves us with very little specificity. So I can have any of the symptoms with any severity pretty much any of the time. If we go to the Autism Society of America and we look at the definition of autism that they have, which has not changed now probably in the last 10 years, is referred to as a complex developmental disability that typically appears during the first 3 years of life. It affects the person's ability to communicate and interact with others. It's defined by certain sets of behaviors and is a spectrum disorder that affects individuals differently and to varying degrees. There's no known single cause for autism, but increased awareness and funding can help families today. That's what you read on the website of ASA regarding the definition of autism. When you look at the DSM-4 criteria, one of the things that they pointed out up until then was that it was a behaviorally defined neurological disorder. And the reason why they pointed this out is because they were still fighting the perception that autism is the result of upbringing. It is severely incapacitating. And I think that a lot of times people have trivialized the diagnosis. But when you have an impairment of communication and socialization, the degree of impairment that causes in your life can be quite significant. It is important to also recognize that the symptoms appear during the first 3 years of life, and that it affects social interaction, communication, and it creates the patients present, with a stereotype pattern of behavior or a restricted and repetitive pattern of behavior. When we look at DSM-5, what they have done is that they combine social communication and social interaction into one criteria. So now the criteria reads persistent deficits in social communication and social interaction across multiple contexts. The second criteria is restricted repetitive patterns of behavior, interests, or activities. The symptoms must be present in the early developmental period. And in parentheses, we have the first 3 years of life, but actually later on we'll point out that this integrative disorder was eliminated. And what they have found is that the patterns of regression in the autistic spectrum population vary a great deal. And it really depends which skills are regressing, when they're regressing, and to what extent. Another important thing is that the symptoms are causing a clinically significant impairment. And I think that the DSM-5 has been very accurate in pointing out that in order for us to make a diagnosis, the child has to be impaired. And where do they measure impairment? Impairment can be occupational, it can be social interaction, and or health. And generally speaking, what we have is an impairment that will affect their capacity to work at the same level as their peers and to interact socially and communicate. Another important thing is that these disturbances are not better explained by an intellectual disability. Why? Many children with intellectual disabilities, mental retardation, severe developmental delays, present with autistic-like symptoms, but the primary cause of their problem is that they are performing at a much lower level of developmental performance. In the old days, in the 80s, we used to refer to the autistic symptoms as being a qualitative impairment of communication and socialization. And I thought that I always thought it was a very good way of describing the symptoms, because it describes the problem as how you relate, not how much. If you think of a disorder like depression, anxiety, ADHD, those are quantitative disorders. The symptoms are typical. Everybody pretty much has experienced depression and anxiety Everybody pretty much has been distracted, inattentive, done things impulsively. What defines the problems in those patients is the frequency and severity of the symptoms. However, in an autistic spectrum disorder, what defines the problem for those patients is not how much, but how they do it, how they communicate, how they interact, and of course, the rigid thinking, the stereotypical thinking that is so inflexible, so different than that from others. In terms of the first criteria, the deficits in social communication and interaction, what we see is problems with social emotional reciprocity. Reciprocity is the big word here, the give and take. And that relates to theory of mind. And we'll talk a little bit about that concept later on. So we have an abnormal and atypical social approach. The way that they relate and interact with other people is very different, whether it's respecting personal space or whether there's the way that they greet you that makes it strange, makes it different. I always talk to parents, and when I teach the residents, I tell them, if you think that what your patient is doing is too strange, is weird, think quality first, because that is going to make a big difference in terms of how you perceive the diagnosis. Reduce sharing interests, emotions, or affect. Many of us know from the MCHAT and from the training that one of the things that we look at is joint attention, the proto-imperative pointing, looking at something and pointing to it, looking at the person, looking at the object. And that is a way of, I want to share with you what I'm seeing. Or I bring something to you, I say, hey, look at this, pretty cool, isn't it? Very, very important. The reason why they're doing that is because they recognize that the other person may not have seen that. And I want to bring that to your attention. However, if I don't have good theory of mind, my only perception is the one that I have, my own perception. So when you think about the term autism, auto means self. That is at the core of what the problem is. The individual has trouble understanding that there's another perspective different than his or her perspective. And as a result, there's no need for me to point something that is of interest over there, because if I think it's of interest, you think it's of interest. I cannot feel for you because I'm not feeling it, therefore I cannot feel it for you. So empathy doesn't always develop. And that's what makes those social interactions different. It makes them strange. Now, under the age of 2 years, it's very difficult to assess these complex emotions. Deficits in nonverbal communicative behaviors used for social interaction. This is also very important, because here, in terms of how we say things, what did the person mean by what they said? If I say to someone, wow, you look great today, it would be very different than if I say, wow, you look great today. The words were the same, but the cadence, the prosody of my speech was very different. And that's what carried the message that I gave, was what I said. The same thing that words could have multiple meanings. If I say to someone, give me a hand, I'm not asking them to cut off their hand and give it to me. Maybe I'm asking them to help me. And again, that has to do with semantics. So many times we hear about a semantic pragmatic language disorder, and it relates to these type of things: the capacity to recognize facial expressions, tone of voice, body language, the capacity to understand that a word can have multiple meanings depending on the context in which they're used. So that nonverbal communication is critical. And remember, that is part of language. That is what we refer to as pragmatic language skills. Deficits in maintaining, developing, and understanding relationships. So they don't adjust their behaviors to different social settings. I have a patient that he is a very effusive patient. And every time he sees me, he wants to hug me, except now he's 21 years of age, and he wants to hug me in the waiting room. And I put my hand out all the time, and he tries to get around to hug me any chance he can get. That is inappropriate. We don't do that. Not in our culture. I mean, it doesn't happen here. Early on, what we see is problems with imaginary play, making friends, and the lack of interest in peers. A lot of the parents express concerns that the kids may be lonely, and some of them are, but many of them, quite frankly, are very happy not having anyone around. So, we need to assess that component of their social interaction. In terms of joint attention, which I relayed to before, it's the ability to coordinate attention between an interesting object or an event and another person in a social context. Okay? So I have to use my eyes, I have to use pointing, and I may say, "Did you look at that? Look at that." Or, "Can you hand me that thing over there, please?" The way that we do it in our office, we blow bubbles. Why? Because kids love bubbles. So they get all very excited. And then I watch, how are they going to ask me to blow bubbles again? And many of them just simply stand there waiting for me to do it again. And if I don't do it, they just turn around and do something else. Now, a typical child will typically look at it, get very excited, may even turn to their parents and sort of like, "Hey, did you see that?" And if I don't do it, then they may go, "Hey, bubbles, blow that up again." And that is very typical. How do I assess that in the office? Well, the first thing is, does the child respond when someone says, "Hey, look at that"? And that begins to happen at about 9 months. When the kid is about 12 months, he may go and say, "Hey, look at that. Look at the airplane. Look at the tree. Look at the dog." Okay, so we may see that happening. Later on, they bring to things to show you, because, "Hey, this is a pretty cool toy. What do you think about it?" So if we look at milestones of joint attention, 10 months following a point, 12 months pointing to request, and 14 months pointing to comment. That will give you a pretty good idea as to what's going on. Theory of mind, again, is that the formal definition is the ability to attribute or infer the full range of mental states to oneself and others. Well, if I can only recognize and attribute those that are mine, I'll never be able to get anybody else's perspective. That has to deal with beliefs, desires, intentions, imaginations, emotions. So it goes to the core of our social interaction. It's the ability to reflect on comments of one's own and others' mind. Okay, how did that work? What happened there? Now we move to stereotype behaviors, restricted interest. And a stereotype, by definition, is a mold. So when we talk about stereotype behaviors, what we're talking is about behaviors that we can reproduce exactly the same. Things that are stereotypical in nature. Well, we're most familiar with the motor stereotypies, the hand flapping, finger flicking, tiptoe walking, spinning. But we also can look at lining of toys, flipping objects, echolalia, idiosyncratic faces. So there's some kids that get stuck and repeat the same thing over and over and over and over again. There's some kids that all that they do is they flip objects around. When I evaluate my patients in the office, I just put a series of toys and I watch how the kids play with them. And they usually, a lot of them just go for cause effect toys, like the ones that you press the button and the little numbers pop up, or the Jack in the Box. And it's a very repetitive type movement. They have a big truck, and they're more interested in moving the truck back and forth and piling things up and then taking them out and piling them up again. There's no function to the play. There's no imitative aspect to that play. Another thing that we look at in this patient population when we're talking about restricted and repetitive patterns of behaviors is the insistence on sameness, inflexible adherence to routine, etc. The analogy that I very often use is these children drive a train, not a car. And if you are in a train and you try to change tracks without a switch, there's only one possible outcome, and that outcome is derailment. So, you get tremendous distress associated with small changes in the routine. What do you mean that I need to brush my teeth before I put my pajamas on? I always brush my teeth after I put my pajamas on. Difficulty with transitions. We're finishing this task, we're moving to the other one. That change brings about problems. Rigid patterns of thinking. Things can only be done in a certain way. A lot of people refer to this as obsessiveness. But an obsession is a thought that you recognize that you put in your head. Let's say a concern about contamination. And you know that other people don't worry about germs the way that you do. That thought creates a tremendous amount of anxiety. And as a result, I am compelled to wash my hands repeatedly to lower the anxiety. Except it doesn't lower it too much, so I keep doing it over and over and over again. So that's what happens. The person that has rigid thinking has no thought of it being inappropriate or that other people are not thinking that. So, that could be a problem. One of the things that I talk about and I ask the parents of my patients is, problems, let's say, with food rigidity. And there's some children that can only eat one certain brand of chicken nuggets or will only eat a hamburger. I had a patient that could only eat a hamburger if it was wrapped in a McDonald's hamburger wrapper. And it was the wrapper that was important, not the hamburger. If you wanted that kid to eat a hamburger, you better have a McDonald's burger wrapper. So the parents saved those, because they wanted the kid to eat. That's what they had to do. They will eat a certain brand of cereal. So the parents decide to buy the generic brand. It's not in the same box. They're not going to get it. And sometimes they can look at it and tell you it's not the same brand. So it's very interesting. Another thing that they do is they can focus on the minuteness thing. And I mean, sometimes they have these interests that are very limited. I have a patient whose interest is the Civil War. And he can turn any conversation into the Civil War. Before that was the Titanic, and before that it was the weather, particularly tornadoes. So it is very unusual. We have very young children that are obsessed with dinosaurs or Thomas the Tank Train. Those are very common interests that we see. Another thing that we see with repetitive patterns of behavior is what in the old days we used to refer to as disturbances of sensory perception. And it's a hyper or hyperreactivity to sensory input. So, they can fall and have a laceration or a severe excoriation and it's like nothing happened. But if they get sand on their hand or if you put the wrong kind of shirt or clothing material, they act like you're, burning them or something like that. Same thing happens with textures of food or with smells, oral hypersensitivity, oral hyposensitivity, and visual too. So fascinated by visual patterns, etc. So what are the main changes? Well, we went from the pervasive developmental disorders to autistic spectrum disorders. And, PDD was really not a very clear diagnosis. I think that at least autistic spectrum disorders puts it in a better context. It relates to as a spectrum disorder, again, any of the symptoms in any degree of severity. They eliminated Rett syndrome because what they have now is a description of autistic behaviors that have a specific etiology, a medical etiology. So Rett syndrome would be an autistic spectrum disorder with a known genetic condition dash Rett syndrome. They also eliminated this integrative disorder, very, very rare. And again, the timing and the nature of loss of skills was never very real. For those who have been in the field for many years, when they first came out DSM-3 and DSM-4, they were still debating the issue of childhood schizophrenia. Is it a diagnosis or is not? And they were still debating the difference between autism and schizophrenia in many situations. So the childhood disintegrative disorder related to those kids that did not seem to have autistic behaviors early on, but that all of a sudden developed these symptoms. And some people argue that it was related to schizophrenia, but in reality, if you look at early videos of those kids, you probably, if you're a good observer and very familiar with autistic spectrum disorders, you could identify those kids, because even those whose parents tell you that my child had absolutely no problems until 18 months of age or 15 months of age, when they have had experts look at videos of first birthdays of those children, and they were blinded observers, they could tell you who were the children in there that presented with autistic-like symptoms, even though no one had recognized them at that age. The elimination of Asperger's disorder. Well, you know, they used to say that a child with Asperger's disorder did not have a developmental language delay. That meant that they spoke in full sentences, so syntax was okay, but semantics was not, because they really did not understand multiple meanings of words, and clearly they had a severe semantic pragmatic language disorder. So they were having certain developmental delays that we didn't know how to identify. So what they have done is that they have used, in terms of the categorization of the disorder, with an intellectual disability or without, but it will cover the whole spectrum at this point. They merge all of the different diagnoses, autism, Asperger's, and PDD and OS, into an autistic spectrum disorder. And I think that that is a much more accurate way of looking at it. And the idea was that it's a single spectrum. In other words, this would be like the color blue, but there's many shades of blue. And so a lot of variability, individual variability in how the symptoms present, in terms of severity, the onset and clinical course, the cause of the problem, the intellectual abilities, and other associated conditions. So let's look at early signs of autism. Okay, look at parental concerns. Most parents are really becoming aware at 18 months. They begin to seek professional help by 24 months. And a statistic that has always bothered me a great deal is that 50% of those parents that at the age of, when the children were 2 years, went to their primary care physicians and asked for help, the response was, don't worry. And as I said before, please, if there's anything that you get out of this lecture today, don't ignore that. The most sensitive, the most reliable screening tool that you have is a parental level of concern. So it's critical that we respond to that and pursue appropriate assessments, because a developmental language delay can have a dramatic impact on the child's life, even if they don't have an autistic spectrum disorder. So, you know, early parental concern should lead to further investigations. Do not ignore them. Don't brush them off. If you don't have time to see them that day, set a separate appointment just to address this issue. For the most part, the time interval between the initial awareness and a definitive diagnosis in some studies is as long as 4 years. And that is unconscionable in this day and age. So we're looking for things that we know that these children have as a problem. First thing is they don't have a normal social skill development. That's the hallmark of autism. So whether it's eye contact or aloofness, lack of eye contact or aloofness, failure to orient to name. You know, I usually go to the waiting room in my office and I call the patient's names, and if that child does not respond, that's my first concern. Failure to use gestures to point or show, lack of interactive play, lack of interest in peers. Those are the cardinal symptoms that we have been talking about all along. These are the things that you want to know. If you have a child that has a developmental language delay and poor social skills, that's a kid that you want to watch. Think about this. You can have a deaf patient that cannot talk because they're deaf, but they can communicate. So what we're talking about is a communication problem. If I were to put you in the middle of rural China and you don't speak Chinese and you want food and you're thirsty, you need to use a bathroom, you can communicate with them. But a child with autism cannot tell you what is it that he or she wants out of that pantry. They just stand there and scream. That is strange, that is weird, and that is abnormal. And that needs to be investigated. If there's regression in language or social milestones, you must watch this child. Another important concept to have is that regression in developmental functioning, significant regression in developmental functioning, a loss of skill. 3 months ago, this child was talking. Now he doesn't talk and doesn't look at anybody. That is very abnormal. And when we lose skills, that is a serious concern. And we should begin to think about the possibility of a progressive encephalopathy as a factor here. So don't ignore that. Red flags for communication. If they're not babbling by 12 months, remember, my red flag is if you don't have one more word by 12 months, I'm really going to be in trouble. Not pointing by 12 months. No single words by 16 months. No two-word phrases by 24 months. When they have an abnormal rhythm or tone of voice, that cadence, that prosody, the melody of speech is not there. They could be very loud. They could have a totally different intonation. I had a patient that sounded like a radio announcer all the time. Well, when you're listening to the radio, it's okay. But when the person comes in and says, well, hello, Dr. Tridas, and how are you today? That's pretty weird when a 6-year-old does that. That's what we're watching for. They can start a conversation. Or when they start talking, they don't stop. They don't pick up on the fact that you're, looking around, trying to get away, because they don't pick up on nonverbal cues, because they only listen to the words. So those are some of the things that we're looking for. When the child is not smiling by 6 months, when they're not imitating facial expressions by 9 months, when they're not responding to their name by 12 months, when they have poor eye contact or they don't appear to hear you, and you know that they can hear because you did a hearing screening on this kid, but they are not responding. When they don't bring things to show you, when they only want to be playing by themselves or when they're in a world of their own, those are the kids that we want to monitor. Of course, and I have many patients that, well, my kid couldn't have autism because he's not rocking or spinning or flicking their fingers. And that can happen or not happen, but we need those kids that have it, we need to explore it better. Those kids that are much more focused on parts than the whole, and they would look at a pen or an object like this, like it contained the universe for hours, that is someone that you want to watch. So how do we make a diagnosis of autism? Well, the Academy of Pediatrics provided us with a wonderful toolkit to assess kids with autism, and I would encourage each and every one of you to get it. I believe that it only costs $35. You upload it into your computer, and you can print out from there information for the parents' letters. It has links to websites. It's fantastic. So they talk about detection of autism at 3 levels. One is routine developmental surveillance, which happens with community providers and general pediatrics offices in a childcare setting. Level 2 is a specific screening for autistic spectrum disorders using specific screening tools. And level 3 is a formal evaluation to make a diagnosis, and that's typically when you go to a diagnostic center, to a subspecialist to make this diagnosis. On a well-child checkup, typically the recommendations of the Academy are to check for milestones at 9, 18, 24, and 30 months. And they use ages and stages and the BEDI for doing the typical developmental surveillance. Hearing screening is typically done in all of the kids at birth. And then we use the MCHAT at 18 and 24 months. And those are the guidelines that we are getting at this point. There are other specific screeners that are used, the social communication questionnaire, the child with Asperger's syndrome test, but the MCHAT is the one that we're using the most.